All right, so before we take a metabolic pathway deep dive, I do want to spend a few minutes talking about an important concept relating to shock, and that is sepsis and septic shock. This is something we run into, and there's a lot of terminology that I want you to at least be aware of, because this is stuff that is important in categorizing patients and thinking about what's going on with patients. So first of all, let's just get some basic definitions out of the way. So what is sepsis at the end of the day? Somebody has sepsis, what is that?
Advanced infection.
An advanced infection? An infection?
Systemic.
What does that mean?
Affects all cycle processes in the body.
It's like, would it have something to do with like getting into the blood?
Maybe. Yeah, so sepsis, okay. The basic understanding of sepsis is the following. It is the presence of bacteria in the blood. Occasionally you can get something called viral sepsis, right? But often sepsis is bacteria in the blood. Now, does that mean that you are critically ill? Not necessarily, okay? So just saying that somebody is septic doesn't really tell us much, okay? Sepsis is simply the presence of bacteria in the blood. Now, what can happen in response to that presence of bacteria in the blood is what may or may not make sepsis nasty for our patient, right? We often associate sepsis with nasty things, but at its core, sepsis is simply the presence of bacteria in the blood. All right? You guys okay with that? May or may not be a problem. So there are some other things that we need to think about. All right? Some other things that suggest that this is problematic, and there are really two paradigms that are being used right now. The first paradigm is something called SIRS.
Oh, okay. They recently changed that,
There's some controversy, and we'll talk about it. All right. Does anyone know what SIRS stands for? It stands for systemic, inflammatory, response syndrome. Okay, systemic inflammatory response syndrome. That means that this person has systemic inflammation, right? And we've talked about what inflammation is. This is inflammation occurring on a organism-wide level, all right? There are 4 major criteria. And if your patient has 2 of those 4, all right, that suggests that they are in SIRS, all right? So, what are the 4 criteria of SIRS? Let's do this instead. There we go, we'll make that A. So the first criteria is temperature, all right? Hyper and hypothermia, right? So if the patient has a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius. All right. Does anyone know what normal body temperature is in Celsius?
Celsius.
What?
it's like
Look it up. You need to know this. It's normal body temperature in Celsius.
36.8.
Say it again.
36.8.
36.8 to 37. You guys okay with that? Yeah? Okay. Because that's kind of an important thing to know. All right, so. All right. That corresponds with a temperature of about 98.6 to 99, right in there, okay? All right, so that's the first of the 4 criteria, is the temperature. The second is based on heart rate, right? And typically it's a heart rate greater than 90 per minute. The third, respiratory rate. And generally, that's going to be greater than about 20 per minute. And of course, we're talking about an adult patient here. There are slightly different thresholds for kids, obviously. And then the fourth criteria is the white blood count. And that tends to be greater than 12,000. Does anyone remember what the normal white count is? Or less than 4. Does anyone know what the normal white count is? So the normal white count is 5 to 10,000. All right. So greater than 12 is leukocytosis, right? Less than 4 is leukopenia. So if your patient they have an infection and they have 2 of these 4, we say that they have SIRS. They have systemic inflammation. You guys okay with that? Now here's the controversy. The controversy is there is another system that is being used by some places, and that's called the Sopa Score. And there are some places that suggest the Sopa Score may be better, and then there are places that suggest SIRS may be better, right? So there are some different criteria that are used. And Sopa stands for Sequential Organ Failure Assessment. Sequential Organ Failure Assessment. Okay. Maybe something that you run into in the hospital. I am going to go over the Sears criteria simply because these are, at least some of these are things that we may have reasonable access to, right? Whereas the Sopa Score, we might not be able to get the whole picture there, all right? You guys okay with that? Okay, so that's SIRS, right? So if they're septic, you got to ask yourself, well, do they have SIRS, right? If they do have SIRS criteria, that suggests that the sepsis is problematic, right? Now, there is also something called severe sepsis. Severe sepsis. Does anyone know what severe sepsis is?
Circling the drain at that point.
Okay, but what would indicate that somebody has severe sepsis as opposed to sepsis?
Altered shock velocity, hypotension.
Hypotension, shock? Actually not. Yeah, it's actually not based on, it's not based,
It's, a new organ dysfunction.
yes. So severe sepsis is if you have a septic patient. And we know what sepsis is, right? They have bacteria in their blood. Sepsis plus the presence of organ dysfunction. Okay, sepsis plus organ dysfunction equals severe sepsis, right? So if you have, there is bacteria in the blood, and they have evidence of one or more of their organs failing, that is severe sepsis. That doesn't necessarily mean hypotension. That does not mean that they're hypotensive, right? They could have elevated liver enzymes, right? Their liver's taking a hit. That's severe sepsis, but their blood pressure could be okay. Does that make sense? Right? So it's not a blood pressure thing, right? It's, is there evidence of the liver failing? Right? Is there evidence of the kidneys failing? Okay, those are two of the most sensitive organs that we often see impacted by this. But you could have other organs and organ systems. And then finally, the most severe manifestation of sepsis is something called septic shock. And what is septic shock?
Bleed working good.
No. To say that somebody is in septic shock, there are some criteria that have to be met. Well, first is what? Maybe, but first of all, if to say somebody's in septic shock, what do they absolutely have to have? They have to have sepsis. Does that make sense? So you have to have sepsis to be in septic shock. That's the first part of it. And then what?
Organ dysfunction.
Possibly, yeah. I'll likely have organ dysfunction. But what makes septic shock is refractory, and this is important to write down, refractory hypotension. Okay? Refractory not just hypotension, but refractory hypotension. What does that mean when I say refractory hypotension? It's resistant to treatment, right? So if you have somebody with an infection, right? Maybe they have a pneumonia or a wound infection, right? And you pick them up on scene or you're taking them out of facility and you notice their blood pressure's low. You cannot just jump to saying, oh, this is septic shock, right? You can suspect sepsis, you can suspect severe sepsis, you can even go through some Sears criteria. But what you do is when you attempt to resuscitate them, if you cannot resuscitate them, then they are in septic shock, right? So they look like they're septic, their blood pressure's low. What do we typically do? We give them fluids, right? So you give them fluids, you challenge them with fluids. If their blood pressure remains low, in spite of your attempts to correct it, then you can say they're in septic shock. Does that kind of make sense there? So there are several different things wrapped up or that can fall under the umbrella of sepsis. Okay, you guys good with that? Makes sense? Okay, excellent. All right, and I bring this up because this is important, right? And we're running into this quite a bit. Now there is one more thing that I want to mention, and this isn't specific to sepsis. It's a broad thing, and it is something that's used in critically ill patients. And I don't want you to memorize the components of it because it would be difficult for us to use in a pre-hospital context, but definitely in the hospital, when we have the information, we can use it. And it is something called the Apache Score, or more appropriately, it's known as the Apache 2. The Apache 2 score. All right, and this is a scoring, this is an evaluation that we can do to critically ill patients. So it may be a septic, severe septic, or septic shock patient, but it can be other patients as well. And the Apache stands for Acute Physiologic Assessment and Chronic Health Evaluation. Right? So acute physiologic assessment and chronic health evaluation. Right? That is the Apache 2 score. And so what I'm going to do is I'm just going to bring up how the scoring is done. And what this score does is it gives us some idea of what the mortality is going to be for this patient, right? Based on some criteria. It gives us some idea of what the mortality may be for this patient. So, let me turn this on here. So I'm shamelessly referencing mdcalc.com. Okay, there we go. So this is the Apache 2 score. right? So again, it gives us some estimate of what the possible mortality, right, the death, right? So when do we use it? Right, all patients newly admitted to the ICU. It's not necessarily mandatory in some places, but it's a good tool for identifying patients that may be at higher risk for mortality. All right. So these are the inputs, so to speak, right? So does the patient have a history of organ failure or immunocompromise, right? Heart failure, cirrhosis, chronic lung disease, they're on dialysis, right? Yes or no? So remember, the Apache score is both acute and chronic things that we assess, right? So, yes or no, right? Organ transplant?
Yes.
Yeah, right? Because they are immunocompromised. Yeah. All right, and then we put their age in. What is their body temperature? And this calculator is nice because it does Fahrenheit or Celsius, all right? What their mean arterial pressure. Do you guys remember how to calculate mean arterial pressures? Or the map? We're going to talk about it in cardiology.
I can't remember.
So mean arterial pressure, that's the average pressure in the blood, in the vasculature, right? So mean arterial pressure equals systolic, whatever your systolic blood pressure is, plus 2 times the diastolic. Remember, you spend twice the amount of time in diastole that you do systole, right? And that all gets divided by 3. Why? Because 1 part of the time you're in systole, 2 parts of the time you're in diastole, right? If you want to find the average, what this is a mean, right? You need to divide by the full 3 parts time, right? So systolic plus 2 times the diastolic divided by 3 gives you your mean arterial pressure. Normal mean arterial pressure is 70 to 100 millimeters of mercury. So you put the mean arterial pressure in, you get an ABG, you put the patient's pH, their heart rate, their respiratory rate, their sodium, their potassium, what is creatinine? Kidney function test, good, right? And then you ask, hey, does this patient have acute renal failure or not? You put in the patient's hematocrit, their white blood count, their Glasgow Coma scale, and then the amount of oxygen that they're on. What is their FiO2, right? How much oxygen are we having to give them? You put all this information in, and let's just put something in. How does that sound? So let's put a relatively healthy patient. 41. The temperature, let's just put in 98. Mean arterial pressure, let's put in 90. pH, let's put in 7.4. Heart rate, let's just put in 80. Respiratory rate, let's put in 16. Sodium 140, so all normal values. For potassium 4. Creatinine, let's put in 0.9. No renal failure. Let's put in 45 for the hematocrit. Let's put in 5 for the white count. Glasgow Coma, let's put in 15. Non-intubated. And their PaO2 is greater than 70. So they have 0 points. So about 1% post-operative mortality, or 4% non-operative mortality if this is a patient that does not need to go to the operating room. So pretty low risk, right? That makes sense. So let's go ahead and make them moderately ill. So let's say they have some chronic disease going on, right?
How much stock do providers put into this? Is it a large part of their decision making?
It depends on the provider.
It's for surgery, right? Usually.
No, pre and yeah. Again, in the result, we'll do this again, and I'll show you the result. Let's say that this patient has moderate, maybe have fatty liver disease, right? They have fatty liver disease, and we had to do an emergency appendectomy or non-operative, right? We don't this is not necessarily, but let's just say that this is somebody that we had to do an emergency appendectomy on. You guys good with that? Right, so we had to take their appendix out. Their temperature, let's say it's 100. Let's say their mean arterial pressure is okay. Let's say their heart rate's a little elevated. All that's good. Let's say their white count is a little elevated following surgery. Okay. We'll give them a little altered mental status and see what's happening to the points. They just keep going up. And so now we have about a 7% estimated mortality. Not really super high, right? But just kind of giving them, you know, a moderate illness. And then what we can do is, you know, if they're electrolytes, let's look at that. Let's increase their creatinine a little bit to 5. And let's say they're in acute renal failure. Now what? Now 30%. Does that kind of make sense there? Right. So it's not exact, but it gives you an idea of, oh, okay, this particular patient is much sicker than that last patient, right? And I'm more concerned about this particular patient.
Do you change the age or have anything to do with it? You put
Oh, absolutely. Let's make this a 71-year-old person.
35.
Yeah, it added, you know, additional 5% mortality just based on age alone. Yeah. So anyway, it's a calculator you can go to, you can play around with it. And the really neat thing is when you guys get to clinicals next semester, do that. I mean, this would be a great thing to do on those sick patients in the ICU, right? To actually go into the chart, right? Which you should be doing, right? You should be getting labs. You should be getting some good history. And actually doing this, you don't have to memorize it, you just do it right here. If you want to do the Sopa Score, there is a little MD Calc allows you to do the Sopa Score as well. Right. This is actually the quick SOFA, this is not the full-on SOFA, so this is something you could do at the bedside, right? And it's just altered mental status, respiratory rate, and systolic blood pressure, right? So is their mental status good, their respiratory rate's good, their systolic blood pressure good? Well, they're not high risk. If you want to do the full-on SOFA score, it's a little more involved, as you can see, right? You need to know their PaO2, their FiO2, are they on a ventilator, what's their platelet count, what's their GCS, what's their bilirubin, all right, that's looking at the liver, what's their mean arterial pressure, or are they on dopamine, epinephrine, norepinephrine, what dose, what's their creatinine, right? So you can see that the full-on SOFA score is going to be a lot more difficult to obtain than the Sears criteria for our purposes, right? Cool. You guys okay with that? All right.
The Apache Score,
Yes.
when we had to sit down with other providers when they took my dad off of life support,
Oh, okay.
and he didn't go into detail, but I think that's what he was referencing. That's why I asked you how much weight does it carry with providers?
Well, Apache is not really something that we would use for like, I wouldn't
Because they were
typically
giving,
use
they were
it
giving like
to have that.
percentages, like
Yeah.
he's like it was like an 80% chance that he would even come out.
And that might be a part of it, but I mean, I wouldn't use that as like a primary tool. Like if I was gonna sit down and talk to family have a conversation about, hey, do we wanna keep doing this or not? It might be one of the things that would come up, and it's
Like I said,
probably,
he never specifically
Yeah,
said
it
Apache,
may-
but he was giving like the percentages, like this is where we're at, this is.
yeah, this is probably part of it. Oh, nice, I need to update something. This might be something they use, I don't know, I don't wanna speak for that particular provider.
But it was a group of them.
A group of them, yeah. I don't wanna speak for them necessarily, but this, the Apache is more of a, okay, I have this patient, you know, what's going on, you know, how close do I need to watch this patient, how concerned am I about this patient? That's kind of more what the Apache Score was developed for. I'm not to say that you couldn't use it for other things. And again, I don't want to put words in any provider's, you know, mouth. But they definitely could have been something. You know, obviously if the liver enzymes are really high and the BUN and creatinine's really high, you know, those are you know, indicative of pretty severe organ failure. Yeah. I don't know if I answered your question appropriately or not.
I mean, it was kind of, they didn't go into all that, you know? And at the time, I wouldn't know what they were talking about to begin with. So.
Yeah. And it can be, like even here, it even says, they can be used to determine prognosis and help family members make informed decisions about the aggressiveness of care, right? So it can be a tool that can be helpful. It's just, you want to be careful because this is statistical, right? This is not like a literal, it's literally a 30% chance of, it's, you know, if you have a large group of people that have this same kind of score, right, they're, you know, 30% of them will say die, right? And so it's just, it's definitely a tool that can be used. It's just, yeah, you want to be really careful about how you communicate with the family, because they, you know, obviously you gotta be real careful. Okay, you guys good with that stuff there? So hopefully. And again, I am not mandating or requiring that you guys memorize any of this, right? You've got the calculators. You can use them. You should be able to use them. I just want you to be aware of these are out there, that these tools are in fact out there. Okay, so now what I want to do is I do want to take a deeper dive into these metabolic pathways that we talked about a little earlier. So the first thing I'm going to talk about is the so-called cell respiration. And so let's go ahead and enlarge this a little bit. All right, so here is specifically looking at glycolysis, the Krebs cycle, and the electron transport. All right. So you can see there's a lot of stuff going on underneath the hood, right? So glucose is coming in, right? And glucose gets converted to something called glucose 6-phosphate. Now this is important because many of these intermediate steps between glucose and pyruvate, you guys see that there? Many of these intermediate molecules can be sent over to other cycles, right? So the glucose 6-phosphate, for example, this glucose 6-phosphate gets sent over to another cycle, right? You remember when we talked about nucleic acids at the beginning of pathophysiology, and I had mentioned a cycle that was important for producing nucleic acids in the human body, and that was called the pentose phosphate pathway. Well, those ribose and pentose sugars that are important, that form kind of the foundation of the nucleic acids, they actually come from the pentose phosphate pathway. And this glucose 6-phosphate is the starting molecule for that pathway. So glycolysis not only feeds into the Krebs cycle and the electron transport, but it also feeds in, and when I'm done here, I'll pull this up and show you, it feeds into the pentose phosphate pathway, right? So you can see that these are all highly interconnected. And here we have the NAD pluses coming in. The hydrogens are attaching, and now you have 2 NADHs coming out. At a couple of steps, so do you see this step here? And this step here, do you guys see that there? Right here, these two steps, ADP molecules are coming in and being turned into ATP. So I have 2 molecules of ATP getting produced here, but I'm using what? I'm using 2 molecules of ATP up here. So do you see how ATP becomes ADP? You see that there? So this takes energy right here, right? And there's actually an enzyme. Essentially each step of all of these cycles, there is an enzyme that catalyzes that chemical reaction, right? Each step along this cycle, there is an enzyme, right, that catalyzes that reaction, right? So you need to use energy here, and you need to use energy here for this to continue. So I subtract 2 ATPs here, and then I add 4 ATPs here, which gives us how many? 2 at the end of the day. We net 2 of them, right? And that's all I get out of here. All right. So at the end of the day, what happens is pyruvate comes out, right? And pyruvate gets converted into something called acetyl coenzyme A, or acetyl-CoA. All right? So pyruvate gets turned into acetyl-CoA, and then it gets fed into the Krebs cycle, and this is actually within the mitochondria, right? So this is in the middle of the mitochondria, and then the mitochondria has a membrane, right? It has 2 membranes, an outer membrane and this inner membrane. And then this space in between the membranes is known as the intermembrane space or the intermembrane matrix, right? And it is right in here where you actually have the electron transport occurring, right? The Krebs cycle is occurring out here. So acetyl-CoA gets fed into the Krebs cycle. You guys see that there? And the acetyl-CoA goes through several different steps, and these are some of the major molecules that are produced. Citrate. Citrate is known as citric acid. So that's why the Krebs cycle is sometimes referred to as the citric acid cycle, right? So acetyl-CoA gets turned into citrate, ketoglutarate, succinate, fumarate, and oxaloacetate, and there are actually many other steps. These are just some of the major steps, right? And so what do you see? So do you see how I have a 6-carbon sugar, or 6-carbon atom that gets produced? You guys see that there? So I have 2 pyruvates that come in. So I start off with glucose, and it gets converted into 2 pyruvates. Each have 3 carbons, and then pyruvate, acetyl-CoA, and acetyl-CoA gets turned into citrate. So I have 6 carbons, and then what happens is, at each step along the way, right, I'm kind of pulling oxygens and hydrogens off of those carbons, and the carbons are decreasing, right? So 6, 5, 4, right? And the carbons and oxygens get combined to form CO2, so carbon dioxide's coming out as a waste, right? And then what's happening is you've got NAD here, or NAD plus here, NAD plus here, NAD plus here, and FAD, and they are coming in and they are taking those hydrogens and electrons that are getting torn off of these molecules here. You guys see that there? And then these NAD, the FAD becomes FADH2, the NAD pluses become NADH as the hydrogens are attaching on, and then all those hydrogens get sent over here, right? So the hydrogens build up in this intermembrane space here. And then you have these series of enzymes here, right? And you can see 1, 2, 3, 4, 5. You guys see that there? And so what happens is the electron comes in at high energy, and it hits this first enzyme here, and then it bumps down to the second enzyme, and its energy is a little lower, third a little lower, and then the fourth the lowest yet. And then the electron comes out here as waste. You guys see that? Now at the very end, the last enzyme here is something called ATP synthase. So what happens is I have a bunch of hydrogens that have built up. You guys see that there? And what happens is hydrogens flow through this channel. So think of this as like a dam. This is like a dam, and you have a bunch of water behind it. And what can you do if you dam up a bunch of water? Well, you can put a pipe in that dam, right? And that pipe can go through a generator. And then what happens is the water flows out of that dam, right? Because it's all dammed up. So a bunch of potential energy there. That water will flow out of the dam through that pipe. It'll spin that generator, right? and that'll generate electric power. Does that make sense? That's called hydroelectric power. Something very similar happens here. You can look at these hydrogens and these electrons as like water behind a dam. And then as they flow through the dam, through these pipes, that powers the production of ATP. And the majority of it happens right here at ATP synthase. And this enzyme literally moves. It actually turns around as the hydrogen flows through it. It's actually something called proton motive force, or PMF. So as these are kind of like water, as these hydrogen ions move through, it kind of spins that enzyme around, and what that enzyme's able to do is it grabs a hold of a phosphate molecule and attaches it to ADP. So it turns ADP into ATP as it spins around. Does that make sense? You guys okay with that? And then ATP starts kind of spinning out there, right? And so here you have the NADHs, the FADH2s, they're dropping off the hydrogens and the electrons, and then they are being converted back into NAD pluses and FAD, so they can go back into the Krebs cycle. And you actually have some of that occurring here in glycolysis as well, right? Now, complex 4 here is an important one, and this is one of the complexes where oxygen is actually used. So oxygen comes in here, and it acts as that electron acceptor for all of this waste that's coming out here, right? The electrons and the hydrogens. And that's called cytochrome C oxidase. So this is where oxygen needed, right? Convert this stuff into water molecules. Okay, so you guys okay with that, right? Okay, so those are kind of the major things that we see going on there. This is often referred to as oxidative phosphorylation. This is collectively referred to as oxidative phosphorylation. Right? So we are phosphorylating, we're adding phosphorus to something through an oxidation reaction. Because ultimately you're adding oxygen there. All right. So now what I want to do is I want to take a quick look at the Cori cycle. All right. So remember, the pyruvate, if the Krebs cycle is working, the pyruvate can get converted into acetyl-CoA and go into the Krebs cycle, right? If you have excess, so this is in the tissues right here. So if you have excess pyruvate coming out, that pyruvate will get converted to lactate, right? Or lactic acid. Now, as long as things are working, that lactic acid can go to the liver, right? And it can get turned back into pyruvate. But look at this right here. You see that? It takes 6 ATP molecules to convert that pyruvate back into glucose. And as you might imagine, there are enzymes involved here as well. Make sense? So this takes a lot of energy. So the cells need to be making energy. Does that make sense? Right? For this to work. If it works though, the pyruvate can be converted to glucose, and then the glucose can be sent back to the cells to be used. This whole kind of thing is known as gluconeogenesis, or the new generation of glucose. But this cycle here involving the conversion of lactate into glucose is known as the Cori cycle. And does this make sense why this cycle will not work in a shock state? Right? Because the cells just can't make enough ATP for this to work. And so what happens, this shuts down, pyruvate backs up, lactic acid backs up, and you get that lactic acidosis. So does that kind of make sense there? Okay, cool. So that's gluconeogenesis in the Cori cycle. Let's go back here. Let's talk about the pentose phosphate pathway real quickly. And the pentose phosphate pathway is important for a couple of different reasons. And so what I'm going to do is I'm just going to open this image it'll let me. I would like that image to be a little larger. Let's see if it'll let me save it to the desktop here. If I can make it a little larger for you guys, I will. So this is just shamelessly taken from Wikipedia, but fair use for educational purposes, we'll say. Okay, that's a little better. Okay. All right, so this is a pentose phosphate pathway. So do you guys see at the very top here, glucose 6-phosphate, or G6P? You guys see that there? So where is that G6P coming from?
The liver.
Is it coming from the liver? Remember, glucose 6-phosphate is coming from from glycolysis, right? It's one of the intermediate steps in glycolysis. So glucose 6-phosphate, right, from glycolysis primarily, gets fed into this cycle. And you can see that we have different enzymes that catalyze this. And this is how we make these ribose sugars, right? That ultimately form the backbone of the nucleic acids. All right? You guys okay with that? Now there's another concept, another pathophysiological concept that I want to bring into this. And this is a reasonably common problem that we run into. All right? And it involves this enzyme right here. You guys see this enzyme right here? This enzyme is glucose 6-phosphate dehydrogenase. And so it should come as no surprise that this is an enzyme that catalyzes a dehydration reaction. And remember, we talked about dehydration reactions? We said that dehydration reactions usually result in combining of molecules. I think the example I gave you was of amino acids, right? The peptide bonds that combine amino acids are the result of a dehydration reaction. I think the rule of thumb that I told you guys was dehydration synthesizes and hydrolytic, right, or breaking down of water tends to result in breaking down of bonds, right? So dehydration synthesis and hydrolytic lysis or cleavage. Well, this enzyme here is an important one in that there is a genetic disorder that people get where they have a mutation that results in an inadequately functioning glucose 6-phosphate dehydrogenase enzyme. All right. This is also referred to as G6pd. G6pd is how we shorten that. Now, I know there's at least one other Army medic in here, right? Did you have to deal with this when you work people up for physicals?
Like pre-deployment physicals?
Pre-deployment physicals. Was this something that everybody got tested on,
Yes.
right? We tested them for something called G6pd deficiency. Now, when I was in the military, I didn't know what the hell that was. I was like, oh, that's either bad or good. Oh, bad if you have deficiency, good if you don't, right? That's about all I knew. Well, guess what? G6pd deficiency results from a mutation that prevents this enzyme from working effectively. This glucose 6-phosphate dehydrogenase enzyme. And in G6pd deficiency, what happens is these patients are not able to effectively metabolize this glucose 6-phosphate into these intermediate steps. Right? Now, as long as this patient isn't stressed out, they don't have any medicines on board or anything like that, they generally do okay. The problem comes into place if we happen to stress these people out. So they get an infection, okay? They get stressed, or they get exposed to certain medications, right? And this is where it becomes important when we talk about deploying to other countries. Medications like Primaquine, for example. Does anyone know what Primaquine is used for? This is just one example of how this is a problem. Well, Primaquine is a medication that is used to treat and or prevent malaria. It's an anti-malarial medication, right? And what can happen in these cases is if this patient has G6pd deficiency and they get stressed, they get infection, or they get put on certain medications, right? What will happen is it will throw a monkey wrench in this cycle, and there will be some highly reactive molecules that will be produced. Some reactive oxygen species, we talked about those earlier, some free radicals to get developed that are highly toxic to red blood cells. And this will induce a hemolytic anemia. And these patients will have severe hemolysis that develops, right? And they'll become anemic, and then those busted up, broken up red blood cell fragments tend to clog the kidneys up, and they can even go into kidney failure. Right? Does that kind of make sense? Right? Yeah, but there we go again, right? Talking about the kidneys failing again, right? Yeah. Interestingly enough, this can also be brought on by ingestion of certain foods. The most common food that can precipitate a crisis in these patients include fava beans. The ingestion of fava beans. Yeah. So does that kind of make sense there? So you can see how there's a lot of interrelatedness going on here. So what I'm going to do is I'm going to turn this off. I'm going to pop this up here. And then we'll just see about kind of interconnecting things again. Okay. Perfect. All right. So, you guys see the pentose phosphate pathway here? So again, G6P, glucose 6 phosphate, from glycolysis gets fed into the pentose phosphate pathway, and what comes out of it? Well, pentose and ribose sugars for making nucleic acids, but there's some other things that come out too. There are some other things. Fructose 6 phosphate and glyceraldehyde 3 phosphate come out of pentose phosphate, and that they can actually be fed back into glycolysis. So these two feed into each other. Do you guys see that? See how there's that interrelatedness there? Another thing that happens, another thing that comes out of the pentose phosphate pathway is something called NADPH. NADPH is very similar to the NAD plus, or the NADH. You see the NADH here? It's very similar to NADH. But NADPH is very important because what it does is it shuttles electrons to cytochrome P450 enzymes. How the hell about that? You guys remember what cytochrome P450 enzymes are responsible for? Yeah, like 90% of all drug metabolism occurs as a result of cytochrome P450 enzymes, at least phase 1 metabolism, right?
It's like on 99% of my cards.
Yeah, 99% of your drug cards, right? It says metabolism, primarily hepatic, cytochrome P450 enzyme, CYP2D6, right? Or whatever. Yeah. So for your P450 enzyme system to work in your liver, it needs NADPH to come out of the pentose phosphate pathway, and the pentose phosphate pathway needs glucose 6 phosphate to come out of glycolysis, right? And here we thought, oh, it's hard enough just to remember glycolysis and its role in ATP production, but it's broader than that. It's more interconnected than that, right? And so what happens is your drug comes in, right, to your cytochrome P450 enzyme pathway. Your drug comes in, your R, and you ultimately add a hydroxyl group to that. You hydroxylate the drug, right? ROH, R comes in, ROH comes out. Well, how do we do that? Well, we need to add electrons to it, and believe it or not, oxygen actually comes in as well, right? The cytochrome P450 enzymes are oxygen binding enzymes as well. So they are somewhat similar to hemoglobin in that sense. Right? So there's a lot of substantial interconnectedness going on. It's been an hour. I was gonna try to finish up, but I think I'll give you guys a break and then we will finish up this deep dive and get you out for lunch. So get out of here, take a little break.